Okay. It's just now the top of the hour. I try to say that because it's 4 o'clock here and it always ends up being at some 9 o'clock or 8 o'clock. So I'm letting a few people in to the from the waiting room. We'll give everybody it does take just a few minutes for people to come on sometimes. So we'll give everybody a minute or two and then we will get started. So grab something to drink. The excitement is about to begin. Okay, there are a few other people that are coming in through the waiting room, but I think I can just kind of get started. So we'll go ahead and get started with the introductions. Um, thank you everybody for being here. It is October, it's pumpkin spice time and all the fun that comes with that. And so thank you for joining us for the October version of the JVS Online Journal Club. Tonight we are excited to have a couple of great papers that we are going to have presented. I am going to start with just a few introductions. Um, the young surgeon's host was to be Nico Giancopoulos. I think that he's having a couple of technical difficulties, so he may come on in a little bit and join us. But we are thrilled and fortunate to have two great institutions, Cedars-Sinai and Honor Health. Dr. Dawn Burrill, who is an associate professor of surgery and the program director there, along with Jessica Effred, who is the second-year fellow, and then Dr. Richard Rogers, an assistant professor of surgery, and Dr. Shiv Patel, their second-year fellow as well. It's always wonderful whenever we have the authors here, and Dr. Young Kim is here to help answer questions about the Surgeon of the Week. I know I have a lot of questions about this and thinking about implementing it. Dr. Weisler and Dr. Coleman could not join us, but those are his co-authors on the work. And then one of the exciting things for me is Dr. Cao from the Chinese Academy of Medical Science is here to answer questions about their 10-year experience with dissections. Dr. Shu is on a plane and won't be able to make it, but it's very exciting to have an international presence with us tonight. Dr. Linda Harris, who is the president-elect of the Society for Vascular Surgeons, will be one of our special guest moderators. This is an exciting thing for us to have her here, as well as Dr. Elizabeth Chow, who is an assistant professor of surgery and one of the JVS editorial board members to moderate with us. So please stay muted. I will encourage you to submit your questions or comments in the chat. We may call on you if the question is complicated for you to go to just be able to verbalize it for us. This is being recorded for on-demand access, and the next JVS Online Journal Club will be November 12th at 6 p.m. Central. We will have LSU and the University of Tennessee, and if you need more dates for the end of the year, it's the second Wednesday of the month at 6 p.m. Central Time, but it is on vascular.org. So I will stop sharing my screen and I will turn it over at this point so that we can have Dr. Effred get us started.
Thanks, Dr. Humphreys. I think I'm going to actually just give a couple intro slides. Can everybody see that appropriately?
We can. I didn't mean to forget about you, Dr. Burrell. I'm
Oh,
sorry.
Oh, nice. Yeah. All right. Appreciate it. So, yeah, I think we're all kind of excited to hear a little bit more from the Duke crew about their new approach to call. So obviously we're going to do a little more of a deep dive from Jessica, our second year fellow, then anxious to hear from Young and some questions. I think we all know this vascular surgeons play a vital role in any hospital system. I think two big things that we act as firefighters addressing, intraoperative emergencies as well as any vascular trauma. And as well, certainly at our institution, we have a big role as enablers, so assisting with elective surgery, whether that's spinal approach or oncologic resection. And I think concomitantly, we all know that our patients often require urgent or emergent interventions. And that leads to quite a few challenges in balancing your elective outpatient workload along with the call duties. So the concept of these alternative call models or acute care vascular surgery, and we'll hear from this certainly in more detail, but might include things like improved patient care, decreased length of stay for the patients, fewer canceled elective surgeries, increased overall surgical volume for the entire group, improved surgeon quality of life, and along with that, hopefully less surgeon burnout. That being said, I certainly had some questions. I imagine all the readers do, but one, do these alternative call schedules really work? So, this paper was pretty encouraging, but maybe we'll hear some boots on the grounds from Dr. Kim, if indeed this is as good as it sounds. What about smaller groups? So the Duke group seemed big enough to have sort of a key number of players to do this, but can this work in smaller groups? One thing we suffer from here is really limited OR and cath lab access. So how does that work in a big system like Duke? Is there always the available room, and how does that play out? How best to include all surgeons within the group? So what if someone does, 90% veins or access? Do they take call for everything in this model? And then finally, how do the surgeons perceive this change? Has this been really well received over the course of the couple of years that this has been tried? So looking forward to hear from the authors, and Jessica is going to give us a little more of a deep dive into the paper itself. So I'll stop sharing and hand it over to her.
Can everyone see my screen appropriately, or is it in the weird presenter mode?
It's in the presenter mode, so if you just want to swap the displays, that should be fine.
Okay. How's that? Better?
I don't see it anymore. Is it just me?
We don't see it either.
Yeah, I think you'll have to share it again potentially.
Mhm.
There we go. Go for that. Perfect. Thank you.
Okay, is that better? Okay, so really the goal of this paper, as we kind of discussed already, is to report this institution's experience with their Surgeon of the Week model over a 1-year time period. And the whole goal here is to compare the efficiency of inpatient care with this new Surgeon of the Week model versus the traditional on-call model. And to really give insight into other institutions, and honestly, for people like me trying to find a job in the next couple months, what the benefits and maybe setbacks there are in this kind of model, and how it can be beneficial to both the patients and the surgeons involved. So the definitions that we need to kind of think about are this pre-SOW, pre-Surgeon of the Week model. This is kind of the more run-of-the-mill 24-hour call-based schedule where the surgeon's responsible for all the inpatient, emergency department, and inter-op calls from 6 a.m. to 6 p.m. There was no formal backup call system. So if someone was occupied with the case, there was no set, next available surgeon. I take it as just whoever was sort of available had to fill in the gaps there. And then the weekend call was from 6 a.m. Friday to 6 a.m. Monday. The Surgeon of the Week model is a single surgeon who covers all the daytime inpatient consults and all the operations associated with those from 6 a.m. to 6 p.m. But they did not have any overnight or outpatient clinic that week and minimal elective cases. So they're really kind of focused on just their on-call and consults for that week. And then the Surgeon of the Week service, it became one service line, and then the elective service, it sounds like was the other surgeons who had elective cases, and a different group of trainees or APPs were kind of taking care of those patients in a separate service line. So this is just a depiction of what that initial kind of run-of-the-mill 24-hour on-call surgeon looked like. So you had surgeon one who covered, one day, and then there was 6 surgeons total, and this is kind of how they broke the schedule up. And this is a depiction of this doctor of the week or surgeon of the week model, where someone's covering from 6 a.m. to 6 p.m. So the methods they used to gather this data were through the electronic medical record, and they reviewed all the vascular operations during the course of that year that the Surgeon of the Week model was implemented. And this is from May 2023, from May 2024, all the data was collected prospectively and was retrospectively analyzed. The pre-Surgeon of the Week data was collected from May 2018 to April 2023. And there were 6 surgeons who participated in this model in this institution. The data that was collected included the role of the vascular surgeon, the case urgency, whatever that case was, whatever the primary surgeon listed, what service they were associated with, the case type, the operative time, and any external transfer requests. And this study, again, the whole focus is this a more efficient model to take call? So they looked at the total proportion of weekend operations, what cases occurred at night, any elective case cancellations, which is really important when evaluating this, and then preoperative length of stay. And that was defined by the time between the patient getting admitted to the hospital and their inpatient operation. There were 2,486 cases that were performed by the Surgeon of the Week, or during the Surgeon of the Week period, and 598 were performed by that Surgeon of the Week specifically. The pre-Surgeon of the Week period included almost 9,000 total cases, and the overall volume was higher in the Surgeon of the Week period. So the average annual volume in the pre-Surgeon of the Week period was 1,700 cases per year versus that 2,400 that was seen in the Surgeon of the Week model. Here's another depiction that was in the paper that really showed the how many cases were completed in these different groups. So it was represented over 51 weeks. I think 1 week was excluded for holidays. Again, the total operations were 598. That's 11.5 cases on a weekly basis. The hourly total was 1,476. That weekly hourly total was 28.6. And there were 302 total transfer requests. So among the 598 operations, the Surgeon of the Week was the primary surgeon, and the majority, or 82.3% of the cases. Elective cases comprise 78.3% of operations. And these are, again, inpatient procedures that were performed on a non-urgent basis, like amputations for dry gangrene or inpatient angios for tissue loss. There 13.5% were urgent and 8.2% were emergent. 14 non-vascular surgical services were listed as the primary service during these procedures, most commonly ortho, neurosurgery, cardiac surgery, and trauma and ACS. The Surgeon of the Week did perform a lot of different cases, so a lot of the breadth of primary vascular operations. The most common indications for primary vascular operation included acute limb ischemia, aortic dissection, carotid disease, hemodialysis access, maintenance or revision, and major amputation, followed by mesenteric ischemia. So compared with the pre-Surgeon of the Week period, the pre-op length of stay was actually shorter in the Surgeon of the Week period. It went from 2 days versus 3 days. Most of the significant improvement in expedited care occurred among elective inpatient cases, with reduction in median pre-op length of stay from 5 days in the pre-surgeon of the week period to 3 days during the surgeon of the week period. There was no significant difference in the pre-op length of stay for urgent cases or emergent cases, which showed that, those were being most likely prioritized in both, in both of the call models. It shows improved efficiency in managing elective inpatient cases, and patients who needed time urgent operations were able to achieve those in both scenarios, which is great. And the elective case cancellations and the proportion of weekend operations were similar in both periods. 10% of cases versus 8% of cases in the surgeon of the week period occurred overnight. So there was not really an increase in the burden of overnight cases with the surgeon of the week model. So again, this study aimed to reduce conflicting cases of the on-call surgeon, to improve the delay in inpatient care, and to improve continuity of care. So the surgeon of the week is, on every day, seeing these patients every day. I think a couple of things, it does require equal buy-in from all parties. So if you have someone who is really busy doing outpatient or vein cases in the clinic, they have to be as, encouraged to be part of this model as someone who's really clinically busy in the hospital. And the cohort of surgeons needs to be large enough. So you have to, one thing they mentioned is there's a lot of burnout if the surgeon of the week is the same person taking call on either bordering weekend. So being able to have a big enough group to where you're not going to burden the surgeon is important. So I think all those things are good to consider. The limitations of the study: it was a single center, it's a retrospective analysis. Perhaps there are some confounding variables. So the increase in volume during that surgeon of the week year that they looked at, it could be because in the pre-surgeon of the week era, that included COVID. There could be a natural increase in census. I think it's difficult also to quantify the cost of less clinic for these surgeon of the week surgeons, the less scheduled elective cases versus the value of having someone always available. So I think it puts, and I see examples of this in our institution all the time, I think it puts other services at ease knowing that vascular is readily available, to aid in whatever they may be taking on or whatever case they're doing. I think it's difficult to quantify the value of this either way. And then there's no information on the case volume of the individual surgeon. So I would be curious to see, some of these surgeons, were they operating a lot more during this period versus less in the pre-surgeon of the week period, and even how it could aid in new grads kind of developing their practice, if there was any kind of difference in that. So in conclusion, it showed a more efficient delivery of inpatient care, and I think it overall enhances safety of other service lines. So thank you guys, and we'll kind of continue to discuss.
I think those were great comments, and this is a very exciting presentation, something that we've all seen from our colleagues in trauma surgery and acute care surgery who've gone to these type of models. But I think this does bring up a couple of questions, and I'll ask a couple more and then let the authors comment too. So one thing is you said that the surgeon was going to be more available than the normal on-call surgeon, yet they're doing 11.5 cases per week between 6 and 6. So the question is, are they really more available, or are they not more available? Because that's a fair number of cases to do during that time. And then also addressing how you handle the transition between later in the day versus going into the evening. Clearly, it didn't change the number of evening cases or weekend. And how did you get the hospital to prioritize having a room sitting empty, not just to do the emergent cases, but the elective the urgent? Because that's the biggest issue that we all have, is having an operating room or cath lab that's going to sit empty, designated for these kind of cases. So why don't we start with that, and we'll let the authors comment. And then if people have questions from the group, please put them in the chat and we will make sure the authors answer.
Yeah, thank you for allowing us to present our article here. Thanks for the great presentation, Dr. Efford. think with regard to the block time, I think that that's an excellent question. Um, I think at first we were seeing what block time was not utilized, but was granted to our group. And we were able to take advantage of the block time that was not actively being utilized. For example, if we have a hybrid room every day, but if it's not completely filled up all the time because of case delays or cancellations or whatever, then we were able to use up that time. And then we were able to take some of our data on the urgency and emergency of some of our cases, and we were able to collaborate with our anesthesia colleagues who run the OR board, and then demonstrate to them how many cases we have every day, and we meet with them every morning and discuss with them. These are the cases that need to get done. These are cases we have in the wings that may be pending for the day, and they help us utilize available block time. Most frequently, the trauma ACS room that can be sitting around that's often used by them. We're able to take advantage of that. I think there's a great question in the chat about addressing some of the resistance as this was implemented. And that's an excellent question. We have been discussing this alternative call model for close to a year before it was actually implemented. So every month we would get together and discuss each iteration about what people would like and would not like, and how we should go about it. And everybody was on board by the time it was implemented. I believe in May of 2023 is when we finally rolled it out after close to a year of discussion. And it wasn't perfect when it was implemented, and we've made some changes since then. But everybody was on board when it first started, and I think everybody's on board now. Although the 1 in 8 weeks. We started 1 in 6. It's 1 in 8 now since we have two partners that joined. Everybody does every operation. We have venous partners as well, but they're mostly on the outpatient side of things, and they don't take inpatient calls. So we're fortunate in that end, in that all of our partners who are in the main hospital do all the cases. So they were open to taking this alternative call model. I would say 1 in 8 feels much better than 1 in 6, but I think it's important to have buy-in from all the partners before transitioning.
So how many surgeons do you think you need to have to make a system like this work? And also, when you talked about you have time available, if your block time drops in your institution, how many days before does it drop? And can other services steal your hybrid room or other ORs if you're not utilizing them? And how do you combat against that?
That's a great question. Block time utilization is a bit of a moving target for us. Ideally, we have it filled a week ahead of time, but in speaking with the anesthesia team, as long as we have it filled up within 48 hours, we're good to go before we have to release it for other teams to take over. That being said, our block time utilization during the implementation of this model and for that 1 year was somewhere around like 70 to 75%. So we have been doing pretty good from block time utilization standpoint.
That helps. So one of the metrics you used was you called it length of stay, but you measured from when the patient came in till when you did the procedure.
Yes.
And that also doesn't necessarily take into account when was the patient diagnosed with the vascular problem. So you didn't even do it from the time that you consulted. And there are plenty of times patients are in the hospital with pneumonia, and oh, by the way, they have dry gangrene, or they came in with a host of medical problems, pneumonia, and now they have acute on chronic renal failure and are going to need an access. So do you think that was the right metric to use, and how else can you better assess length of stay issues?
Yes, that's an excellent question. If we had the readiness for OR to date of OR date, that would have been the ideal metric to use. Unfortunately, that's a little bit hard to gather through retrospective chart review of 2,400 or so cases. So that's why we've used the date of admission to date of OR is more low-hanging fruit.
Okay. I think probably one of the biggest questions that I would imagine, no one else if people in the audience have questions, please put them in the chat, but I don't see anything coming up right now, but is really the satisfaction of the surgeons. Because if you can do it without losing money, without losing time, and you guys are happier, then that's something we would probably all be interested in adopting if it's feasible. If it's not making, because it's not making a difference between evening and weekend cases. So we're still going to operate all night and all weekend, that happens. Are we going to be happier during the daytime? And why?
For us, anecdotally, we all are happier with the transition and call model. It's hard to be operating all day, all night, and then have a full day of clinic the next day. So to have somebody who is the pinch hitter in-house, taking care of all the inpatient consults, taking care of, the cleanup list that's around and everything that comes in through the door when we can focus on our own practices for the and then come in and do and then serve as the surgeon of the week or the doc of the week and when you have to do it. I believe it was the Rochester group that looked at the quality of life, and they all said they were happier. We just didn't have the opportunity to survey all our partners, but anecdotally, we are all more satisfied with it.
So there's a question from the chat. Can you talk about your compensation model? Are you on a salary with RVU and other bonus for productivity? Was there a leveling of case numbers with WRVU between the partners or not?
We are all salaried, so we are not compensated based on our views.
So this makes no difference in terms of the number of cases, and that might be an issue for groups that are RVU based then. Can you also address what changes you made from the time you started till later? You said you made some changes with how the process was working.
Yes, absolutely. I think the biggest change was going from a group of 6 to a group of 8. I think other things that we had tried was the super surgeon of the week, where we had a weekend before and then went straight into surgeon of the week for continuity purposes, or a weekend of surgeon of the week or week of the surgeon of the week, and then going into a weekend of call afterwards. Yeah, that seemed to be too onerous, just with the volume of operative consults that we have. So we learned to space that out a little bit further. And we also moved the switch over time between 5 and 6 o'clock PM a couple of times. I think that's something that's important. That was very important for us and maybe important for others who are considering this model is you have to have buy-in from everybody. There are a lot of operative consults that are going to come in at like 5:30 p.m. or 5 a.m. and that's clearly going to be left over to the person that's coming on. So everybody has to be it's a team sport ultimately.
There was also a question, is there a chief rotation for the trainees associated with this, or are they not really involved with this?
We usually have one senior level trainee, whether it be a vascular surgery fellow or a senior vascular surgery resident, who serves as the surgeon of the week resident. And then they switch back and forth between the elective service and the surgeon of the week service.
Okay. There's another question from the chat about reconciling why the rate of elective cancellations didn't decline, but the pre-op the LOS for elective cases went down with the model. Can you clarify definition of elective cases and why do you think this happened? Is this because the SOW still had elective cases booked, so it really wasn't different from the normal model, or is it something else?
That's an excellent question. In terms of elective cases, that accounts for a total of proportion of cases over all the cases that were done, not just the inpatient cases that were the surgeon of the week. We were hoping to see a decrease in not having to bump yourself and cancel your own case to do a surgeon of the week case. Unfortunately, we didn't see a decrease there. But the elective case cancellation is for outpatient elective case as well as the inpatient elective case cancellations. The preoperative length of stay for surgeon of the week going down. I think you said that's an imperfect metric, but those are for patients who came in through the emergency department or through the transfer center and then were admitted and were waiting for a surgery. And that was the time that went down for those non-urgent, non-emergent cases.
And there's one more question from the chat. Was there consideration of having the night call added to the SOW, or is that considered too burdensome?
That's too
a full
burdensome.
week.
Yeah.
And do you have any situation where you covered more than one hospital? Because you have a group of 8 people now, starting with 6, where you're covering one site. So how would you handle this if you have a surgeon who's covering more than one site, which happens at a lot of places as well?
Yeah, absolutely. We have a regional hospital and a Veterans Affairs hospital within our group as well. But everybody has different amounts of allotted time and protected time at each of those. So everybody who had some call at the main hospital was included in this call model. And when they were on Surgeon of the Week for that call, then they would cancel or have somebody else cover their clinic time at the VA, for example.
So they'd be off for a week maybe from the VA and wouldn't have any cases there or clinic?
then one of the other VA partners would cover for them. So they cover for each other. Yeah.
Okay. I think we're right around the halfway mark, correct,
Absolutely.
Dr. Humphries?
Thank you,
All
Dr.
right.
Harris. And thank you, Dr. Kim. I think there are a lot of questions for this paper simply because it's different and we need to explore different ways to do things, especially as the nature of what we do expands and gets to be more urgent. So, and multiple times we've talked about burnout in many different avenues, and trying to mitigate that is really important. We're now going to switch gears and we will have Dr. Rogers come on and from Honor Health. And Dr. Cow is here to answer questions from this paper. And then, of course, Elizabeth Chow is the moderator.
Good evening, everyone. Thank you, Dr. Humphries, and thanks to the Society of Vascular Surgery for giving us the opportunity to participate in our first JVS online journal club. My name is Richard Rogers. I'm a associate program director here at Honor Health, and right next to me is Dr. Shiv Patel, who's a second-year fellow in our program, who's going to be discussing the paper. Shiv, would you mind just going to the second slide? So the paper that we're going to be talking about this evening is weighted 10-year survival and neurological outcomes after Zone 2 thoracic endovascular aortic repair for acute type B aortic dissections. We are joined tonight with the first author, Dr. Cow, and the senior author is Dr. Xu, who could not make it tonight from Fuai Hospital in Beijing, China. It was just published this month in the Journal of Vascular Surgery. And this manuscript asks a very important question regarding the outcomes of patients who receive or do not receive left subclavian artery revascularization in zone 2 TVARs, specifically for acute type B aortic dissections. As most in this audience know, vertebrobasilar ischemia after TVAR, and especially in zone 2, is secondary to the left vertebral artery malperfusion. Previous studies have demonstrated that 60% of patients have a dominant left vertebral artery. And further, previous studies have shown that intentional coverage of the left subclavian artery is associated with posterior circulatory strokes in about 1.5 to 5.5%. A large systematic review and meta-analysis from Mayo Clinic from Rochester, Minnesota, also showed a very high odds ratio for left arm ischemia and vertebrobasilar ischemia in patients who have had intentional coverage of the left subclavian artery. So currently, our society, the Society of Vascular Surgery practice guidelines, have a grade 2, level C, which indicates that it's a low quality of evidence recommendation for preoperative left subclavian artery revascularization prior to TVAR in the elective setting. The SVS strongly recommends grade 1, again, level C, low quality evidence for preoperative revascularization in certain patient scenarios, which Shiv may highlight as well. You know, patients who have a prior Lima cabbage, or the termination of the vert into a pica, and others that Shiv will discuss. Further, it's very important, especially in the setting of thoracoabdominal aneurysm repair, to make sure that any spinal cord perfusion is preserved to try to avoid spinal cord ischemia. Now, a lot of these studies that the Society of Vascular Surgery has used to make these recommendations have mixed pathology. So this aortic aneurysmal disease, or dissections and other etiologies as well. So further, for acute thoracic emergencies, again, it's a grade 2 level C recommendation, which is most relevant to this manuscript. That it should be quote unquote individualized and addressed according to the patient's anatomy, urgency of the procedure, and availability of surgical expertise for the left subclavian artery. So as I mentioned, we have a grade 2 level C recommendation. The data supporting those recommendations are not very robust. And Dr. Kyle's paper seeks to elucidate some of the details regarding this very important question. And I think from there, I'll hand it over to Dr. Shiv Patel. Thanks so much again.
Hi, I'm Shiv Patel, vascular surgery fellow at Honor Health. Thank you for allowing me to present today. So let me get started here. So we'll be presenting today the weighted 10-year survival and neurological outcomes after Zone 2 TVAR in acute Type B aortic dissections. So TBAD or Type B aortic dissection has an estimated incidence of 1.5 per 100,000 patient years. TVAR has become the mainstream kind of treatment modality in treating Type B aortic dissections acutely. Currently, there's debates whether LSA revascularization should take place preemptively for patients who require Zone 2 TVAR coverage, Zone 2 TVAR with LSA coverage. The studies that were done in the past looked at mixed aortic pathologies, but there are very few studies that are centered on acute Type B aortic dissections, as this study is. This study intended to evaluate the 10-year outcomes following Zone 2 TVAR with LSA revascularizations in acute Type B aortic dissections. Currently, if you look at the guidelines like Dr. Rogers talked about, the SVS guidelines suggest that LSA revascularization should take place in patients who've had prior Lima cabbage or termination of the left vert into a pica, absent or occluded right vertebral artery. They've had a AV fistula prior in the left arm, or prior open or endovascular aortic aneurysm repair of the aorta where spinal cord perfusion could be compromised. And so these are kind of the biggest things to look at. And one more thing is also if you have planned coverage of the descending thoracic aortic segment or hypogastric occlusion in patients that have a concurrent aneurysmal disease. So for this study, the methods were, there's a retrospective cohort study between January 2010 to December 2020. Patients that were excluded had a traumatic or iatrogenic TBAD, had connective tissue disorders or other congenital cardiac anomalies. And if TVARs were placed with the proximal seal zone caudal to Zone 3, they were excluded. The endpoints that the study looked for were the primary endpoints included the CVAs during follow-up, which was defined as a composite of ischemic and hemorrhagic strokes. And then the secondary outcomes were technical success, Type 2 endoleak, post-implantation syndrome, length of overall hospitalization, the 30-day mortality, and CVA, ischemic strokes, and major adverse cardiac events. The post-implantation syndrome was defined as a fever of greater than 38 or a white count greater than 12 in the first 72 hours after implantation of a graft. And then the technical success was defined as a TVAR without any Type 1 endoleak or any in-hospital mortality or 30-day CVA. And then a CVA was itself defined as a composite of ischemic and hemorrhagic strokes. The acute Type B aortic dissection was defined as any aortic dissection that came in with symptom onset within 24 to 14 days, 24 hours to 14 days. So the authors looked at the proximal landing zones of the TVAR grafts and evaluated the entry tears on CTA with 3D reconstruction on all the patients. There was either open or percutaneous access for the groin access, and cut downs were performed for brachial artery access for any branch stents. LSA was revascularized via branches, fenestrations, physician modified grafting or chimney, or left carotid to subclavian bypasses, and then left subclavian to carotid transpositions as well. These patients were followed, and then completion with the completion angiogram and follow-up CTs were performed in 1 month, 3 months, 6 month, and 12 month, followed by annually. The mathematical analysis was performed with a propensity score weighting, which was used to balance the confounding factors, which compared the LSA revascularization to LSA coverage groups. They used both the multivariate and univariate analysis, and Kaplan-Meier estimates were performed to estimate the freedom from MACE and the incidence of ischemic stroke and CVA. There was a special kind of propensity score weighting used in this study, which I had not heard about before, which is called inverse probability of treatment weighting. And they used this score because the patient sample size was smaller, and it using the IPTW allowed for the cases to also be included in the final analysis, which would not have taken place with the standard matching algorithm. So from 2010 to 2020, 601 patients were analyzed. 348 patients were excluded for either traumatic TBAD or iatrogenic TBAD. 3 patients had Marfan syndrome. Some patients, N=1 of concomitant aortic coarctation, and majority of these patients had a zone 3 TVAR, which excluded them from analysis. So from there, 253 patients underwent zone 2 TVAR, and they were included in this study. And from this, you see there's an unadjusted analysis, and then the weighted cohort analysis, which was with the IPTW scoring system. That basically created a database of patients, which were similar to the unadjusted analysis of patients. So in regards to the baseline characteristics, there was a statistically significant difference in there had a longer follow-up in patients that had LSA coverage versus LSA revascularization, with the length of follow-up was longer in LSA coverage by 123 months versus 71 months. And there was no other statistical significant findings in the baseline characteristics. In the baseline characteristics of the patient's comorbidities, with the unadjusted demographics, there was some statistical significance in hypertension and peripheral arterial disease, as well as coronary disease, with more patients having peripheral arterial disease and coronary disease and LSA revascularized patients, but this was not found in the IPTW-based analysis. In terms of the baseline radiographic findings, there was a statistically significant difference in the groups in both the unadjusted and the weighted samples, with the patients having a higher incidence of balanced vertebral artery dominance in LSA coverage patients, as opposed to LSA revascularization patients. This is a table 2 that it's showing the perioperative variables. So the perioperative variables, and here you see the operative duration was statistically significant in both the unadjusted and the weighted sample, with the LSA revascularization taking about 30 minutes longer. Table 2 continued here. Here I show you the length of stay was also something that was studied. So in regards to the postoperative outcomes here, there was a higher length of stay in the ICU and hospitalization after the weighted samples were analyzed. In patients undergoing LSA revascularization, they had a 22.59 hour ICU stay versus a 19.04 hour ICU stay in patients that had LSA coverage. Length of hospitalization was overall longer in LSA revascularized patients, in 10 versus 8.76 in patients that had LSA coverage. So, and in regards to the medications prescribed postoperatively, the patients that had LSA coverage had a higher incidence of having antiplatelet regimen as well as a statin therapy. With respect to the cerebrovascular accidents, there was a significance found in post-implantation syndrome in the univariate Cox regression analysis, and this was also found in the multivariate Cox regression analysis with patients that had underwent TVAR grafting and showed signs of PIS had a hazard ratio of 2.65 of developing a CVA. In patients that underwent a revascularization within 8 to 14 days of thoracic, type B aortic dissection, they had a hazard ratio of 2.77 of CVA. These are the Kaplan-Meier estimates here. So the IPTW adjusted strokes and CVAs were significantly higher in patients that had LSA coverage over a 10-year period. And this shows basically that the long-term outcomes of patients that underwent coverage of the LSA, they had a higher incidence of CVAs long-term. And here is the survival estimates and freedom from MACE, both showing benefit from surgical or LSA revascularization in between the two cohorts. So in conclusion, the IPTW adjusted analysis of 253 patients undergoing, this was an IPTW adjusted analysis of 253 patients undergoing under zone 2 TVAR for acute type B aortic dissection. The study showed no difference in the 30-day mortality, the CVA incidence, or technical success in patients that had coverage versus zone 2 TVAR with the LSA revascularization. At the 10-year follow-up, there was very similar survival and MACE between LSA coverage and revascularization group without statistical significance. And the biggest thing that the study showed was that the occurrence of post-implantation syndrome had an increased risk of CVA to patients. Overall survival here was 93.3% in the revascularized group versus 87.5% in the patients that had LSA coverage over 10 years. MACE was 91.2 versus 78.5. The 10-year CVA incidence was 4.8 in the patients that had the coverage of the LSA versus 12.1 without coverage. Sorry, opposite. And this was not statistically significant though. And next to the limitation slide here, this was a single center study. There's a retrospective analysis as well. There was no randomization and there was no differentiation between if the acute type B aortic dissection is complicated versus uncomplicated, because that can change how sick the patient is when they arrive. The sample size was not large, and one thing also is that there's no standardization in the type of LSA revascularization that was performed. And they used either chimney or laser fenestration or physician modified grafting. And some patients underwent open revascularization. So that standardization wasn't there. So this is my last slide. So I'll open up to questions.
Great, thanks so much. And Liz Cho here, also from Cedars. Thanks for the invitation to moderate, and to the Honor Health team for their presentation and summary, and to Dr. Sao and his co-authors for this actually very large series of intervention in acute in the acute setting for type B dissection, which is something relatively rare, I think, that we do here in the West and in Europe. And I want to highlight some things before I dive into the questions, because there seems to be a theme. This is a very unique cohort to publish on, because we know that some of the underlying etiology and prevalence in dissections is very different in the West compared to East Asia. We see much more type A dissections here, whereas the prevalence of type B dissections is actually, if I'm not mistaken, more common in East Asia than type A dissections, and at a younger age. And so just to continue from that, Dr. Hingorani said that it looks like the average age was about 49, which is much younger than what we experience here. And also, I'm also curious on what was the most common indication for repair in the acute setting for your patients? Is it similar in distribution for us? Because we tend to very aggressively medically manage these patients unless they have malperfusion or persistent pain. But it seems like almost a third about of your patients underwent intervention within 2 weeks.
Yes. Thank you, Dr. Cho. Thank you for having me. And thanks, Dr. Patel, for your wonderful demonstration. And thank you, Dr. Rogers. First, I want to address Dr. Hingorani's question. In China and also in Eastern Asia, the prevalence of TBAD is relatively higher compared to Western countries. And we do observe a trend of younger age in our patient. And that is actually why we wanted to do this study in the first place, because we wanted to know if we have a younger ATVAD cohort, how would TVAR, how would zone 2 TVAR impact their long-term survival? And to answer that question, we did this study, and we tried to understand how the LSA revascularization may impact their long-term neurological outcomes. And also, for your question, Doctor, the most common indication in our institution is actually uncontrollable pain, and also visceral malperfusion. And we do follow a protocol that all patients, we don't recommend hyperacute TIVA. Usually, we want the patient to be observed for over 72 hours, and then we could perform TIVA. But we also recommend intervention within 2 weeks, because after the intimal flap becomes too rigid, it may be a little bit more difficult to address through TIVA. And yes?
Oh, no, go ahead.
Yes, and I also want to address Dr. Harris' question. Yes, there is a significant difference in the use of antiplatelet therapy after TIVAR. And when we submitted the manuscript, the editorial office was also raised this question. So we performed further sensitivity analysis. We kind of made the cohort into 2 groups, the group with antiplatelet therapy and the group without it. And we have made a supplementary figure, and the results show that the use of antiplatelet therapy does not impact the late CVA occurrence. And also, the area of brain involved in late strokes, we tried to include this information in the study when we designed it. But since we are referral center and most of the neurological images are done in local authorities, in local hospitals, so that kind of data was unfortunately unavailable to us. So we could not specifically address the vertebral distribution of the late strokes.
A question I have too is, since this was over 10-year span study, did you notice any trends in changes in your methods over the time, like in the earlier time doing more bypasses, later time using more branched endografts? You guys also have different access to different types of endografts than we do. Was there any significant changes over time in the contemporary cohort versus earlier on in the 2010 timeframe?
Yes, we we also have a supplementary figure to address this question. So before 2016, most of the Zone 2 cases just have simple LSA coverage. And after 2016, most of the Zone 2 cases have routine LSA revascularization. And also we have observed a trend that as to the methods used during revascularization, in our early experiences, most cases are done surgically. And after 2016, most of the revascularizations are done through on-the-table fenestration and also a new branched endograft. And we also look forward to the use of TAC, of CTAC, which has just entered Chinese market.
Great. Those are the main questions that I had. I'm just wondering, does your center participate in the larger kind of dissection international studies like IRAD, or is there a separate kind of multi-institutional cohort study that you guys can contribute your data in, because it is such a different patient population that we see?
Yes, we do have many dissection cases, and we do have some collaborations with Dr. Nienberg, with the IRAD groups. However, since the cohort in China is quite different from Western countries, we are now organizing a Chinese registry, and now it's enrolling patients. It has involved over 20 aortic centers in China, and the trial is still ongoing. So I'm quite looking forward to the implementation of this study. However, as to international collaborations, due to many restrictions in policy, unfortunately, we tried, but most of the multi-center registries can still be limited in China only. But we do look forward to any kind of international collaborations. That is for sure.
Great, excellent. I'll look for any other questions from the audience. From Dr. Rogers, did this study change your practice pattern? And does your group tend to cover LSA more often than before?
Actually, our group tend to revascularize LSA more often than before, because there's a small point I would like to point out, that although the difference in CVA and ischemic strokes are not significant, we do see a pattern of higher CVA incidence after LSA coverage, so which gives us more confidence to revascularize LSA. And also, our study, one of the main outcomes of this study is that routine LSA revascularization does not add to the 30-day mortality or morbidities. So we think that kind of says that this technique is safe for this kind of cohort.
Well, thank
Dr.
you.
Harmani.
Thank you, Dr. Chow, for moderating, Dr. Harris for being here. It's really great to have an international presence. And thank you, Dr. Sao, for being here. It's very
Thank you
rare
for
that we
having
get
me.
international authors to come and be able to discuss their work with us. And I think you've given us all a lot to think about and understand how things are different all over the place. It looks like there's, was there one more question? I think we can hear a lot. Okay, no, just a
Oh,
comment. Okay, sorry.
thank you so much.
I have to, I can't read that fast, but I also want to thank Dr. Rogers, Dr. Burrell, Dr. Patel, and Dr. Efrid, for being here to talk about all of the work that we've done. It's a great opportunity, and we look forward to seeing you again in November. November 12th, 6 p.m. You can register at vascular.org, and have a great night.